Hi, thanks everyone for tuning in and thanks for having me for this session. So today, following up with what Dr. Ram, my colleague from the same institution has said, I'm going to go a little bit in depth into the different kinds of mechanical circulatory support. And for us cardiologists, when we receive the patient with AMI, cardiogenic shock, what goes through our mind and what are our considerations when we plan for mechanical circulatory support for this group of very sick patients. These are my disclosures, nothing related to today's talk. So today we are going to go through the current paradigms in the management of cardiogenic shock. What is the most up-to-date thinking of how we manage this group of very sick patients? I'm going to quickly go through the kinds of mechanical circulatory support devices available, but our main focus should be on the last few topics. When should we institute mechanical support and what kind of support? And when I say what kind of support, it's alluded to by my title slide, the right kind of support for the right patients at the right time, and it all boils down to the right heart. And lastly, I'll go through some established algorithms for decision making when we are faced with such patients. So what has changed recently when it comes to cardiogenic shock? Gone were the days when the patient goes to a cath lab, gets revascularized, complete revascularization, and then we hope for the best. No, I think that they have moved from that. And as we know, definition of cardiogenic shock has been this for many, many years, a critical state of end organ perfusion because of low cardiac output. There must be hypotension, there must be pulmonary congestion, and there must be signs of organ hypoperfusion. But is that the current thinking? I think some of my previous speakers have covered the SCAI or SCAI classification. This is called classical cardiogenic shock. Nowadays, we think of cardiogenic shock from the spectrum of A to E. A being at risk, anyone with an AMI. B meaning beginning of cardiogenic shock, where you can have normal perfusion but slightly, tachycardic, or there is an elevation of lactate without overt hypotension. And finally, stage C, which is on this slide, the classical cardiogenic shock. And E and D would be very, very severe cardiogenic shock. So our traditional definition is only one component of our current day thinking. We should move upstream before we hit classical cardiogenic shock, anything that we can do. So we should, we'll cover a little bit on this in the later slides. Over the past couple of years, again, there has been a lot of centers and a lot of journals publishing algorithms to manage cardiogenic shock. And we have gone from PCI, cath lab management to a system change so that we can take care of the whole system, do a systematic revision of how we manage cardiogenic shock. Nowadays, hospitals are no longer just simply classified as 24/7 PCI capable center versus non-PCI capable centers. We must think one step ahead. If you are PCI capable, are you shock capable? Do you have standby ECMO capabilities? Do you have standby mechanical support capabilities? And do you have 24/7 cardiothoracic support? So that is one step ahead of what we thought 10 years ago. By having a PCI capable center, we are happy and we are good to deal with all AMI patients. So that is no longer the truth today. So in this European Journal of Heart Failure review article, they drew this very, very nice diagram where we classify hospitals according to their capabilities, and we hope to build a network where all peripheral hospitals can have direct access to a level 1 cardiogenic shock center, which has 24/7 complete complement of services available. This is also echoed by the Americans. So about the same time, Jack also published this article looking at how do we systematically improve cardiogenic shock management. They went a little bit further and they talked about EMS recognition of cardiogenic shock. It's not enough for the paramedics to see ST elevation, go to a PCI center. They should be equipped to say this is a high-risk AMI versus a run-of-the-mill AMI. And if they diagnose a high-risk AMI, they might have to direct a patient to a cardiogenic shock center rather than just a PCI-capable center. And what does it mean by being a cardiogenic shock center? Means, of course, you have 24/7 PCI support, but you must have a team of doctors and surgeons and cardiac intensivists ready to take on these patients, do advanced hemodynamic monitoring and titration of medications based on hemodynamics, and should that fail, provide multidisciplinary decision-making for selection for mechanical circulatory support. So this is currently the paradigm for structural change to manage cardiogenic shock patients. So in a nutshell, what I think would be very useful for us to think of management of cardiogenic shock is not just as one person, one PCI interventionist management or one ICU management, but a collaborative multidisciplinary management of cardiogenic shock. We don't want to recognize shock when they are in the classical shock state. We use lactate for risk stratification. We have cardiogenic shock centers working as a hub where they receive patients from spoke centers to manage the sickest patients. And of course, within the cardiogenic shock center, there must be a multidisciplinary approach towards managing these patients. It's team-based, going all the way from the ED team till the very advanced heart failure and intensive care teams. Hemodynamic guided decision-making is a must, and they must have mechanical circulatory support on standby for patients who don't respond to initial therapy. And of course, interventional cardiologists might be interested to know that the recommendation now is culprit lesion revascularization. Okay, so now knowing how the paradigm of cardiogenic shock has changed over the past few years, then we really need to look very hard at our options with mechanical circulatory support. Of course, many of my speakers prior to me have spoken about the different tools available to us. Maybe I'll just go a quick run through of whatever we have been that's available to the cardiogenic shock population. So in a nutshell, what is mechanical circulatory support? It's a mechanical extracorporeal device that is supposed to help the heart recover or improve circulation in the state of cardiogenic shock or low cardiac output. So the ideal device must be easy to implant, it is easy to maintain, and you only think about it when you need to remove it. It's that simple, and hopefully the nurses can have a very easy time looking after this device in the ICU. Of course, it must provide optimal hemodynamic support, and in this day and age, LV decompression is a must to call it the ideal device. It must be durable and biocompatible. Biocompatibility meaning very low risk of thrombosis, low risk of hemolysis. And of course, in the ideal kind of setting, it allows for chest closure. If the patient can receive some ambulation, some physical therapy, that will be the best. And working for in a system kind of way, it must be cost effective. It doesn't make sense to spend $1 million US to keep one patient alive when it can be spent to benefit many other patients. So these are all our devices. And as Dr. Ram has mentioned, tandem heart has really fallen out of favor over the past 5 to 10 years because of the need for transeptal puncture. So I don't think many centers, even in US and Europe, are using this device, but everything else on this list, very, very commonly used. So of course, intra-aortic balloon pump, we always have to go back to this SHOCK 2 trial. No difference in 30-day mortality, whether you use or don't use intra-aortic balloon pump. In some centers in Europe, they are leaving the intra-aortic balloon pump on the shelf and collecting dust without any usage for years. Of course, our part of the world, we are not as radical yet. Of course, the most commonly used complete hemodynamic support device would be the extracorporeal membrane oxygenator at the ECMO machine. And ECMO, we have long established expertise in many parts of the world, and it has probably the widest indications for cardiogenic shock, any kinds of shock, left-sided shock, right-sided shock, biventricular shock, anything. So the ECMO has wide expertise, very, very good indications, a list of indications. It's easy to insert, rapid. It can be done by the cath lab or by the surgeons as a cut down. it has evolved so much that the circuit is now relatively inexpensive, and you can do a complete cardiac support with up to 10 liters of cardiac output. Of course, we always do a gas exchange module for respiratory failure. The cons of ECMO would be, of course, the famous LV distension, increase in afterload, but don't forget about the peripheral limb ischemia and the relative short duration of support. If you are looking at ECMO, we are probably talking about a week or two of support. So that can be a drawback for someone who needs a longer duration of support. How about CentriMac? So CentriMac is in a way probably the most ideal kind of semi-durable mechanical support in my mind. It's cannulated centrally. It can be, again, univentricular or biventricular support. It is essentially an external VET, and each pump can support up to 10 liters per minute independent of the other pump. So you can support the LV more, support the RV less, vice versa. It's up to you to configure. It has better durability compared to ECMO. In theory, it can go on for months. And again, with the RV support, there is always a gas exchange module if necessary. And this is how the CentriMac looks like. This is a CentriMac support. And lastly, we are going to spend a little bit more time on impeller. So the impeller, there have been a lot of controversial papers published talking about the use of impeller versus balloon pump, whether it has any benefit at all. Dr. Ram has given us some summary. He even talked about this IMPRESS study, which looked at 30-day mortality between impeller versus IABP in cardiogenic shock after AMI. No difference. So this is the Kaplan-Meier curve, absolutely the same. And what was very, very discouraging for many of us was this publication in Circulation last year. It was a US study looking at insurance registry over a 13-year period. They looked at all patients who underwent PCI and received mechanical circulatory support on the same day. So this was that was their inclusion criteria. The date of PCI plus the date of mechanical support, if they are the same, the patients were included. 46,000 balloon pump and 5,800 impeller. Looks like a very, very big registry, very well powered, seems like it at least. And we can see that impeller volume over the years has increased. Probably about 2008, there was when impeller was started to be used in the US. And over the short span of a decade, the numbers have increased exponentially. But the looking at everything, they compare impeller versus balloon pump. It seems that the impeller is doing worse in every endpoint, be it death, AKI, stroke, everything. It seems to be worse than the balloon pump. So that was a bit of a cold blanket for many of us who were looking forward to this study. But remember, this is a registry study. It's non-randomized. We don't know how the patients were selected. The only criteria they looked at was PCI and mechanical support on the same day. Maybe there's a bias towards putting in impeller for the sicker patients. For those people whom they think they can get away with, they put in a balloon pump. There are wide variabilities among centers, amongst interventional cardiologists and ICU teams taking care of these patients. There is absolutely no protocol. So in essence, we can see this as a signal that impeller, maybe these are the things that we need to worry about. But rather than seeing this as impeller being inferior to a balloon pump, it probably tells us that we don't know how to select patients for impeller use. We need to improve on this to make sure patients really benefit, and we are not implanting impellers as a last-ditch attempt just to treat ourselves because we give everything that we have to the patient. So having that in mind, there was we looked at some very, very protocolized management strategies for the impeller. And the most famous of all, Dr. Ram has alluded to, was this Detroit group. The Detroit Cardiogenic Shock Initiative has been very, very, famous in the US when it comes to selecting patients for impeller use and the outcomes after impeller use. So they use impeller after hemodynamic classification of the patients, risk stratifying with right heart catheterization. They tried to implement impeller use before PCI, and they achieved a very remarkable result, which was 75% survival to discharge. So looking at the success of the Detroit protocol and the Detroit initiative, many other centers joined in this initiative, and he has since expanded to become the National Cardiogenic Shock Initiative. The inclusion criteria or the protocol is roughly the same as the Detroit protocol. They just expanded the number of sites using the Detroit protocol, and they plan to enroll 500 patients. We do not have the full results yet, but they published about 2 years ago the first 170 odd patients, and they found that their survival rate was very, very similar to what Detroit Henry Ford Hospital reported. 75% at Henry Ford, and the national cohort 72%. Is it just coincidence? I'm not sure. I am more biased in thinking that they are doing something right and we need to learn from what they are doing. And if we look at the timeline, the kind of historical perspective about cardiogenic shock, despite all the PCI strategies that we have invented, door-to-balloon time reduction, more sophisticated stents, improvement in antiplatelet treatment, for the past 20 years, we have not seen a marked improvement in cardiogenic shock after the age of PCI. So then there is a chance that if we implement a protocolized treatment of cardiogenic shock, similar to what the Detroit group and the National Cardiogenic Shock Initiative they are proposing, we may be able to see a dramatic improvement of cardiogenic shock survival. From the traditional 50%, maybe we can see a 70% kind of survival to hospital discharge. So to get there, of course, we need to be very familiar with what are the kind of devices that we put in for the patients that we see. We need to choose the patients, we need to choose the device, and we often have only one chance to get it right. If we miss the first try, we have a second shot at it, it's probably too late. So we need to do it right, and we do it at the right time. So what is the right time? As I mentioned, this was the SKY proposed classification of cardiogenic shock. To get it at C, classical cardiogenic shock, everyone can diagnose cardiogenic shock by then. Is it a little bit too late? Probably. If we can recognize cardiogenic shock at stage B, meaning there is a beginning of trouble brewing, the patient is more tachycardic than you would like the patient to, there's a slight elevation of lactate, then this would be the group of patients that we need to intervene aggressively to even prevent classical cardiogenic shock from happening. So if we can capture this group of patients at stage B, that would be ideal. Why so? You see, if the patient goes to stage C and something is done wrongly, by the time they reach stage D and stage E, the mortality is very, very bad. If we can intervene at stage B and hopefully, later stage C, that would help prevent some mortality. And we need to have a systematic change in mindset to recognize cardiogenic shock before they even turn hypotensive. So that is the idea. And when we select the device, what really goes through our head would be this, I would propose. Of course, when we talk about what is the right device, it really depends on what is available locally, what is the local expertise, whether there are resources available for very high, expensive devices, whether there is a 24/7 primary PCI or cardiogenic shock team support. And if not, if there is no cardiothoracic surgery at on-site, is there a tertiary or even quaternary center able to take the patients presenting to your center? Then right heart function, expected duration of support, and again, as Dr. Ram mentioned just now, what's the exit strategy? So why are we so obsessed with the right heart? I hope to illustrate everything with this simple diagram, which I drew a few years ago. So before an LVAD or an impeller implant, if the LV is very dysfunctional, it tends to be a bit distended, and there is a bit of right heart compression on the picture on the left. When we start left-sided, isolated left-sided support, what happens? The LV gets compressed because of active drawing of blood from the LV. The septum will shift towards the LV, and there will be increased increased preload to the RV. So you have now increased LV output, which will always be shifted to the RV. If the RV in this distended state and with the increased preload, it's not able to cope, then we'll end up with a lot of suction events on the LV. And despite very high levels of mechanical support, patient will continue to be hypotensive, and that is because of RV failure, acute RV failure. So how do we then be very sure of the RV before we implant an isolated left-sided support? There have been many indices to look at RV function. There are echo indices, MRI indices, and hemodynamic indices that have been studied extensively. And well, in medicine, if we have many ways to look at one thing, that means that doctors really have no idea what they are doing. But with more evidence being published, I think the general consensus is maybe PEPI is probably the easiest to use and a very predictive model for us to look at RV function. If we use PEPI, we probably can get it right most of the time. So PEPI, what is it? It's a very simple index. It requires right heart catheterization. So we just need the PA pressures, systolic minus diastolic, which is the PA pulse pressure, and that divided by the RA pressure. So a PEPI is 3 numbers, an index, and we just need to remember 2 numbers. So if a patient is in AMI cardiogenic shock, which is in the context of our talk, we just need to remember 0.9. If the PEPI is above 0.9, then we are dealing with a RV that is probably going to take isolated LV support pretty well. In the heart failure setting, chronic heart failure setting, or the LVAD setting, durable LVAD setting, we are looking at a PEPI of probably about 1.85, or some people are a bit more conservative, they use 2. So if, again, going back to AMI cardiogenic shock, 0.9 predicts the likelihood of RV failure after isolated LV support. So what happens when the RV needs support? Well, there is an option of the RP impeller, which has been used in some part of the world. Experience not that extensive, unlike LV impeller, but more and more centers are adopting the RV impeller. So that is one bailout strategy. If not, we can always fall back to the tried and tested ECMO. All right. So in essence, if there is any evidence of RV dysfunction before we implement MCS support, I think we don't even try isolated left ventricular support. And next, we need to think about our duration of support that we expect for the patient. If we are talking about impeller, the product insert says about 5 to 7 days, but we are able to stretch it maximum to about 2 weeks. VA ECMO, again, 1 to 2 weeks. If we have the CentriMag, we have the benefit of using the CentriMag, we are talking about months. In theory, there is no real duration cutoff. And then what about our strategy? If we are thinking of a patient with myocarditis, we expect recovery, then it will be a support to recovery. Or AMI, you just need a period of myocardial rest and recovery, get over the acute myocardial shock period, then an impeller or VA ECMO is probably reasonable. But if you are looking at longer duration, then we need to think about whether this patient is a candidate for isolated durable LVAD, or if there is biventricular failure and if there is ready availability of donor organs, then of course heart transplant is probably the best way out for the patient. Of course, if the patient is not a candidate for either of those long-term advanced support or advanced treatment strategies, we really need to have a very comprehensive palliative collaboration with our palliative colleagues, and we need to think about care withdrawal. So going back to everything that we've mentioned so far, this is currently what we have called the National Cardiogenic Shock Initiative, which evolved from the Detroit Protocol. They recommend a systematic, protocolized way of looking at cardiogenic shock to select patients for the right device and implant it at the right time, and as well as to de-escalate support at the right time. So two indices feature very heavily in this protocol. Number one, which I mentioned, PAPI, and second would be the cardiac power output, which was mentioned by my previous speaker. Cardiac power output tells us how good the LV is, whether there's been LV recovery, and it is used as an index to help us tune down our support and eventually withdraw our LV support. So they recommend a few quality measures for any center who wants to implement this cardiogenic shock protocol. They hope to use MCS pre-PCI. The door to support time, they are not even talking about door to balloon time. They use the door to support time of less than 30 minutes. We try to achieve TIMI-3 flow. That means we do a good PCI job. And right heart catheterization should be done before everything, before we do the impeller, before we do PCI. And throughout the whole patient support, we try to maintain a cardiac power output of more than 0.6. And with this, we hope to achieve a survival to discharge in the range of 70%. So this is freely available for everyone on the internet. So it's something that many cardiogenic shock centers have been implementing, ours included. So in conclusion, despite major advancement in PCI technology over the years, mortality for cardiogenic shock from AMR has remained very high, but with the increasing availability of MCS devices and with increasing our expertise in this field, now we have an additional tool at our disposal which can potentially alter the disease trajectory. But always bear in mind, to implement a good MCS program, we need to look at every patient's right heart function with invasive hemodynamic measurements to see whether isolated LV support is sufficient for this patient. If not, we need to have a system where we can have LV plus RV support, whichever device is available for the center. And of course, having a structured cardiogenic shock response team, a protocolized patient selection criteria will be the keys for success in any cardiogenic shock program. All right, thank you.